Well, burns has been something that I've been exposed to right from being a child. And I remember an experience that was quite, uh, at the time, quite shocking. When I was about 11, we lived in terrace houses in the mining village. And there was a sort of gap in the two terraces. So our house was downstream, if you like, and a house two or three doors upstream after this gap exploded. We were all out in the garden, busy working and doing stuff for mum and dad. And dad ran into the house because he knew there was an elderly gentleman in there. And his skin was so badly damaged, he couldn't lift him up without the skin coming away. And so he rolled him in a carpet and carried him out into the street. At the time, he was still alive, but he didn't survive because of the extent of his injuries. And it was, I guess, something I had, you put back in sort of the boxes in your head. But as I went through medicine and into med school and started really exploring this area, I remembered and the trauma that involved, and the pain and the suffering. And so it's just interesting that I had that exposure as a child. And you think, as that was that sort of always there in the back of my mind, waiting to come forward. I don't know.
Yeah, well, it's amazing how many doctors you speak to who do go back to a certain event and say, it seems to have paved the way for a big part of it. And how old were you roughly, would you say, at that
I was
stage?
about 11.
Yeah.
I remember I was because Dad got bravery awards and stuff, but he was always very like reticent about that because he didn't do enough in his head. And but I remember the skin coming away. So I know now that somebody of that age, this is an elderly gentleman with that injury, they couldn't have saved anyway.
Yeah, yeah. No, it sounds very traumatic. And is that well, maybe coming to where you're at now in terms of not to take a massive fork, but just to give a bit of context of maybe the Fiona Wood Foundation or your current role in the Burns ward.
Yeah, well, right now, I suppose that many, 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 many decades later, I'm the director of the Burn Service of Western Australia. I've been in that position since 1991. I also director of the Burn Injury Research Unit at the University of Western Australia. And we've, along the way, we've built and developed a not-for-profit foundation, which was the Macomb Foundation after Harold Macomb, who's a great mentor of mine, and now it's the Fiona Wood Foundation. And that's really has been a vehicle that's supported our research and work for some decades now as well. That it's we live in an environment with an extraordinary health system, yet if we want to really put the icing on the cake, we have to work out how to do that. And our competitive granting system is really challenging and competitive.
Mhm.
And so what do we do in the lean years between the competitive grants? And so what we've been able to achieve is in no small part due to those people in our community and the philanthropists, the companies, the individuals that have helped us along the way by supporting the Fiona Wood Foundation.
Yeah, and what kind of research itself? I obviously, it's a Burns ward itself, so it takes patience. But what kind of research is being done at the foundation?
Our research really is in a network at all the universities in WA, and we collaborate internationally and nationally. But our research is very, uh, oh, I was going to say eclectic, but it does cover a lot of spaces. For example, we have this philosophy that every intervention from the point of injury will influence the scar worn for life, and therefore you can influence along that continuum. So we have programs in pre-hospital and community education and care, as well as programs in exploring 3D printing of skin, exercise and the impact of exercise on outcome, uh, a whole raft of work looking at the neurological impact of burn injury, understanding the impact physically and mentally in the mental illness space. And we work with psychologists and psychiatrists in that space. And so every facet that a burn injury touches on, we have elements of research on in play. And so we will collaborate, for example, with Queensland and New South Wales and Victoria in collecting samples of children from their blisters. And so we're trying to understand, can we, from that fluid, can we predict which children will need surgery, which children are more risk, more likely to have a scar. And of course, we do a lot of cell-based research because the cell therapies is fundamental to what we do. Using your skin cells from a non-injured site and placing it on an injured site. So it's multifaceted. I work with engineers, with data scientists, with basic scientists, immunology, and all sorts of different people, which is we've built a network that's sort of grown over the 30 years, all trying to unravel the sort of uh, the mystery really of how a burn injury affects our total body systems, our immune system, our inflammation, and how we can harness that knowledge to improve care. So it's all very translational too.
Yeah, and I was listening to some of your talks, and it really stood out to me when you were saying that, like a burn, it has so much more, damage than just that physical damage and the psychological damage, and the nervous system damage, and I want to get into that, but I guess talking about the spray on, which is obviously what everyone wants to talk about, the spray on skin, because I think it just gives a good context of, perhaps why you hit the limelight, or the spotlight, and it's very interesting. And then we can kind of go back a little bit, but maybe just talking a little bit about what the spray on skin is, and kind of how it came about. Yeah.
Yeah. Well, the spray on skin is spray on skin cells at this point, but we're hoping it will be spray on skin as
Okay.
we've developed
Yeah.
the 3D bioprinter. But my story in this space starts in 1985 when I was working in England in the burn service in East Grinstead, and I became exposed to the research at the time, taking a little piece of skin from a part that's non-injured and growing in skin cell sheets that were really epidermal sheets. Our skin is in two layers. The epidermis is the outer waterproof layer. The dermis is the inner structural layer that gives us a sort of strength of our skin. And so the epidermis is very cellular, and we could grow that into sheaths. And I was able to be directly involved in a patient in 1990. I was in Perth. By then, I'd come from England to Perth, and I'd heard on the radio the guys in Melbourne who was growing these cell sheets. They'd just come back from Boston, where the technology originated, and I coerced everyone around me, and we sent some skin from the patient in Royal Perth Hospital to Melbourne, and 3 weeks later they came back with enough skin cell sheets to cover the whole of the burn wound of 70% of the body's surface. And that was that laboratory-based tissue expansion. And that was just, extraordinary experience, and made me realize, well, we could do this better. And I'm kind of always trying to figure out how we can do better today, to what we can learn from today to make tomorrow better, sort of thing. And so I connected with a scientist, Marie Stoner, and we started working on how to make it faster. 3 weeks is a long time to have a burn before you start treatment. And so I said, unless we can do this in 10 days, it's not useful. And so we got to grow sheets in 10 days. And then we started to see that the fragile sheets that were less mature were paradoxically performing better. And so then we started harvesting the cells deliberately before they formed a sheet and in suspension. And that took about 5 days to expand the cells. And then we asked the question, could the cells perform better in a different environment? And could the body be the tissue culture flask? So instead of taking it into a tissue culture lab for 5 days, could we actually take the elements of that to the person and put the tissue culture actually on the person, which is what healing is essentially. So then we developed a kit, the ReCell kit, where we've put enzyme and a delivery fluid and cell filtering, and we put it in a box, and we built the box, and we again collaborated. I don't know anything about electronics, and the enzyme had to be made for us, and in a very specific way, and we built it all together. and that's commercialized now. It's got FDA approval and all. So
Mm.
what we do is we put some skin in the box, in the enzyme. It splits like a bread and butter sandwich. It's the layers of skin split, and we harvest the engine room of the cells, of the skin, and we put that straight back onto the body, and that takes about 30 minutes.
Oh wow,
So
yeah.
is where we're at the moment. But can we spray on the framework? That's the tomorrow stuff. And so for the last couple of years, we've been working with engineers and chemists and people at University of Wollongong and Queensland, as well as here in WA, and a group, an engineering group in Venture, and they've built a prototype robotic printer for us. And so we're working with Curtin University as well as the UWA and pulling all that together. And can we spray at the point of care skin, framework, and cells such that we can regenerate skin? That's the big goal that I'm aiming for before I have to retire.
Yeah, yeah. No, that's also, and in terms of the, yeah, growing the cells themselves, does it have to be that own person's skin, or can you use the cells of somebody else?
In some areas in the world, some places they use skin from someone else, or even alternative cells from the bone marrow for someone else. But we have always been from you to you, and that's our systems to avoid rejection and
Mm.
problems that you get from transferring infection from one person to the next.
Yeah. Is there a particular like patient that, not obviously not their details, but is there a particular case that comes to mind where you really saw that this thing was just going to be revolutionary?
For me, it was there's lots of
Yeah, of
patients,
course.
particularly in the early days when we're exploring the range of the technology. But the children's scald injuries are where we've made the biggest difference, where we're able to to restore, sort of salvage, I should you might say, this framework of the deeper aspects of the skin by spraying skin cells on early over the surface, usually from about day 3, and we've been able to reduce that extension of the injury and salvage the tissue. And that's been the biggest area of positive gain. And so 80% of our children that require surgery for wound repair, we will get no visible scars. And so we're still working on the other 20%, but that's been the biggest paradigm shift in the pediatric scalds.
So in the sense of like comparing the a child's skin versus an adult skin, I guess what is the fundamental difference? Like,
It is interesting because there's quite a lot of difference
yeah.
in the framework, and we mature, it gets stiffer and less elastic, and the cells have got more of a regenerative capacity as well. But it's also in context of the rest of the body, and so your skin is a bit of a window to the world. It's influenced by many other pathologies, but certainly there is a paradox in that if you're injured as a child, you will heal faster, but you will scar more aggressively. If you're elderly, you will heal slower, but scar less because you haven't got that capacity to respond. And so the skin, I mean, we can see the skin changes from, how soft a baby is and how wrinkly an old a person is. But it's the responses to injury that are particularly interesting, and trying to learn from that so that we can actually facilitate the best possible outcome is really important.
Yeah, and you touched on this before when you were talking about, how quickly we, or yeah, how quickly you guys treat someone is how much damage it does. And obviously we're talking about, these are really heavy burns that you're working with, and often I guess they can be a few days old that by the time you're working with them. But I know that on some of your talks you're talking about, if you can treat a burn within an hour, it's going to be much better. Can you just talk a little bit about maybe those kind of time thresholds?
Absolutely. I think that's where we do our research in the pre-hospital phase, because the best person to treat your burn is you, and understanding first aid is really important. I've been very keen on teaching everybody first aid, not just for burns, but for other, start the heart, protect the airway, stop the bleeding. and cool the burn. So if you cool a burn wound, it's most effective for 20 minutes within the first hour, but it is effective up to 3-4 hours. And you cool it with clean, cool running water, 15 to 18 degrees, you will limit the damage. And we've demonstrated this, widely published around this space, not just our team, but good basic science from Queensland and New South Wales. And then we've got a big paper where with all Australia, New Zealand burns data. And if people have got adequate first aid, they reduce their length of stay, the risk of surgery, their infection rate. So it really does matter. And it's clean, cool running water really closes down that burn and reduces the impact that you will wear for life. And so no ice is important
Okay.
because ice causes a cold damage on the heat damage, and that is a negative. And that's a bit of a difficulty one because some people put ice on it so they can't feel it. And I mean, it is painful, but cool water is more than adequate.
Hmm.
Ice is very negative.
Yeah. I guess it burns in itself, and
Yeah.
what I and like I said earlier, I wanted to kind of touch on the permanent damage that comes from that, not just the scarring, but maybe talking whether it's the psychological impact, whether it's I guess whatever impacts there are, but beyond just the scarring, what are some kind of common yeah.
Well, it is interesting because people are very aware that burns is very painful, and it leads to scarring that can compromise function, that can restrict movement. Uh, but by and large, the local impacts of burn injury are really well treated, and we live in an environment where, with good treatment early, uh, preventing these complications, we can limit the scarring and we can limit the functional compromise. But some years ago, we had a child who survived an 80% body surface area burn, but unfortunately, he died as an 11-year-old 3 years later with a rare tumor. And we asked the question at the time was, did the burn injury or the treatments, that intervention, change his life trajectory? Did it change his risk of this secondary consequence? And it could have been a coincidence, and it could have been just bad luck, but I couldn't let that go. And to cut a long story short, we eventually have got NHMRC grant to look at population health linked data, and with our researchers, Janine Duke was a driver of this. We were able to get a group of 34,000 patients requiring hospitalization for burn injury and compare that with 34,000 patients of matched severity non-burn injury and 120,000 people, I should say, age, sex, geospatial and socioeconomic comparators. And looking at that big data linkage, it was really opened our eyes to the systemic impact of burn injury long term. And we can see that there is an increased incidence of infections, diabetes, neurological compromise, respiratory compromise, cardiovascular disease, some malignancies, if you've had a previous burn. The surprising thing about this whole exercise was that the majority of the burns in the database were not major burns. We'd all been looking for these things in major burns. We know that a major burn has a massive impact from the inflammation. But what we've discovered is that even a smaller burn leads to a statistical risk in that life trajectory. We're now very focused, and we're building biobanks in both our children and our adults patients to try and understand who are the people that are most vulnerable. Can we use the latest technology to identify those people who will have the potential to for this inflammation or this episode in their life to change downstream? And by understanding the mechanism of that, then we can change our therapies at the source of, if you like. So that's been something that we've really put out there in the world's literature, and it's caused a lot of interest and a lot of activity trying to explore that mechanism. What is it? Why is a burn so inflammatory? We know it is. We know that an excision, and we've done this work, if you make an excision versus a burn, your body responds far more aggressively to a burn than an excision. So why? What is the underlying reason for that? And if we could understand that, maybe we could help others in other fields, diabetes and the heart disease and malignancy and so on.
Hmm.
It's a very interesting area to try and unravel this whole very complex ball of wool.
Yeah, and when you said even a small burn, I guess yeah, and how small is small in that sense?
Yes, a small band can, but we don't know who. It's clearly not everyone, but who is vulnerable. And that gets us down this whole discussion of precision medicine. We treat everybody the best we can. And so to be able to treat you because your parameters dictate your risk is the future.
Hmm.
And this is part of that. It's understanding why certain people are more vulnerable to X or Y or Z. Yeah.
Yeah, sorry. The question I asked was, is there the size of the burn? Like, are you, like how small? When you said a small burn, and and I think you probably answered it by it changes from person to person. But yeah, like would it be say like like a half a limb burnt? Is that kind of a small burn, or even smaller could have an impact?
Well, we don't know how small, to be perfectly
Okay,
honest. We don't
yeah.
know how small the impact is. There's a new project just started here in Western Australia called Origins. We have got a history in WA of doing big data uh, population health projects. Busselton has been going for decades, for example. And so the aim is to collect information of 10,000 children from the point of the mother's pregnancy. And so we have asked if they could ask questions about burn injury requiring assistance but not hospital. And they're 3 years in, and at the 3 year mark, we haven't got the data
Mhm.
or done the analysis or anything, but there are 7% of the children by 3 years who've had a burn of some description. Now, the purpose of us tagging along with the Origins program is to try and actually answer the question: are some people more vulnerable with a burn of the size of your hand? It's about 1% of your body surface area, and does that afford us a vulnerability in somebody else when it's half of their body burnt?
Mhm.
So what does the intrinsic person as responses, how does that influence? And so at this point we don't know, but we're looking at lots of different avenues to find out.
Yeah, yeah, awesome. And I know that you said before as well. You don't, you're still working on the exact therapies because that obviously comes from the research. But what kind of therapies are you finding that are working at the moment?
Well, our therapy at the moment is with resuscitation, pain relief, nutrition. We know nutrition is massively important, uh, and uh, then we start with antibiotics. Do getting have an influence on the microbiome, and so we try and avoid that if we can. But so there's the standard treatment, but then it's well, how do we support someone uh, if they're more prone to inflammation? And we've just done a randomized control trial with 6 weeks of Celebrex, which is anti-inflammatory, versus placebo. And we're just going through the analysis of that now to try and understand, is that influential on outcome? It's a drug that we use normally in our burns, but we've just uh, done, as I say, under more rigorous conditions to try and actually really interrogate the impact and match it with biological specimens so we can try and understand the mechanism. But at this point, will it be immune support? Will it be supporting the bone marrow regeneration? I don't know. I
Mhm.
think there's a lot of things that may have an influence, but we just need to do the basic science first.
Yeah. And when you're working with someone who has had those severe burns, like it seems like there must be going back to the story that you started with, where the neighbor that was burned, and it seems like there must be this real psychological element as well. Like maybe thinking in terms of, for instance, when the Bali bombings, I know that a lot of those victims were rushed to Perth hospitals, and particularly your hospital. Um, yeah, I guess you're working with that psychological element as well. Is that how does that go about?
Well, and it's been an area of interest for a very long time, as you can imagine, because it is a life-shattering event, and how people respond is very individual also. And part of our work at the moment is we collect hair at the time of arrival in the hospital, and then we're measuring the cortisol to try and understand the baseline, and then try and understand taking hair serial and cortisol serially over time to try and understand the impact of just the stress of this. And then we look at, we've done a lot of work around questionnaires, understanding outcomes uh, over the sort of early part of that recovery. And we see the different anxiety, depression, flashbacks, post-traumatic stress. And so working with our colleagues as specialists in these areas, we try and address that by assessing early and intervening. But then there's more, I think there's more to know, and there's more to it than all that. And one of our team has just got her PhD in post-traumatic growth, and she's
Mhm.
explored post-traumatic growth because some people go through go to hell and back, and grow from it. And
Mhm.
how? And if we understood that, that would be enormous help to those who just don't, who are devastated by such an injury. And coping, resilience, can we do resilience training, all these different things. And it's massively influential of who's around you, your support network, and how can we facilitate those things. So there's a lot of work to be done in that. But in our population health data work, we see that a burn injury is associated with a lifelong increase in mental health diagnoses. But what is interesting is in the children who were burnt before the age of 4, we see this increase in teenagers, and many of them have no visible scar. So there is more to it than
Mhm.
it's what you present to the world in a visual, cosmetic, aesthetic sense. There's a lot more to it than that, and I say there's a lot to know.
Yeah, and when you talk about post-traumatic growth, is there when you do have someone who manages to take a bad situation and get a new lease on life, would you say that you try and utilize those people because perhaps they can help someone else who's having a hard time, because they've been in the same boat?
That's a very delicate and difficult situation, and we're guided by our professionals in this space. Is that sometimes people benefit by talking to others who, when they can't see the light at the end of the tunnel, we can explain it, but to see it and talk to somebody who has gone through that tunnel is powerful, but it doesn't suit everybody. So that's done in a very controlled manner. But our patients certainly are across the board, and many of them are supportive of us going forward. And I think there's an increasing uh, movement, for want of a better term, in health to understand that actually we're there for patients, we respond to their needs. But let's, instead of saying, well, I know best, this is what you need, let's actually have a dialogue and understand uh, the impact of our treatments, and how to put it, couch it in a sense that they can actually get the best out of it. So to have the person as part of the treating team is actually really useful as well. And the feedback subsequently, because we get to know these people for a very long time. Some people are in and out and no worries and off they go. But a lot of people, I see children that adults I've seen as kids, because they've grown out of the scars and they need more help as adults or whatever. And so there's a lot of opportunity to really hear that voice and hear that and understand how we can do better in that context as well. Yeah,
Hmm.
and I think that's a really important part of this whole business.
Yeah. Yeah, and going back to the technology aspect, or in terms of the future of burns medicine, is there particular things that excite you? Is there kind of like a place that you want to get to that you can kind of almost see that you could get there, but you're a little bit off? Yeah, just in the future, how do you see it?
Oh, the future is really interesting.
Yeah.
Yeah, there's lots of things. We're working at the moment on with something called the eye knife, which has been trialed internationally for cancer surgery. If you cut through it's with a hot knife, yeah, the gas that comes off can be analyzed by rapid evaporative mass spectrometry, so that you can know the chemistry of what you're cutting through, and you can get like a signature, so you know if the cell is cancerous or not. What we're trying to do is to do similar, but to try when the tissue is not salvageable or not. Is it dead or alive, and will it be dead tomorrow? So the eye knife is really exciting, and that links with the 3D printer, then scanning the surface and then printing exactly what we've removed. And so that whole technical exercise is huge and really important to keep driving forward. But and there's the work around understanding, can exercise influence the inflammation, and exercise associated with cognitive behavioral therapy, is that a good combination in our patients who are recovering to drive an improved life trajectory? And that needs unraveling and really driving home. But my very favorite area that we're working in is in the neurology of the whole burns. The skin is a neural, interface. It's not like the eye, or we don't talk about it in the same way like vision or taste or smell, but sensation is exquisite. And it's, we light touch, deep pressure, heat, all these different sensations. It is a neurologically active organ, and I can tell you from our research, if you're burnt here, your nerve density will change here, your brain patterning will change, and the cells in your spinal cord, just next to your spinal cord, with their dorsal ganglia will change. And so why? And what can we do about that? And so we've done work where we put the hand in a mirror box, and the burnt hand, and by moving the good hand, the brain can be fooled into thinking it's the same as the bad hand. And
Mhm.
so that it improves the speed of healing and gets the hand rehabilitated quicker. The brain, it comes from the work done around phantom limb pain, only we're doing it acutely. Can we actually train the brain to drive to a normal shape? Can we think ourselves whole? Now that is out there.
Yeah.
Yeah,
Yeah.
can we use the power of the patterning of the brain to drive the surface shape? Now, I I
Yeah.
hope one day that we can add to that knowledge, but certainly we're inching away along that, because we know the visualization type things have an influence. So it will be fascinating to see how that area of research goes.
Yeah, because and like you said, you're working through all the research at the moment. But when you see something like you said you're injured in one part and it'll affect another part of the body, and obviously the skin's always regenerating. So is this almost like nerve tissue damage, and then that's being, I guess, carried over to the next like cellular growth? Is that kind of, I guess, what we're seeing? Or
It's fascinating, and certainly trying to understand this is hard, because the nerves are damaged in a given area, but there's a lot of crosstalk that crosses over at the spinal cord level, at the brain level, and then flows out again. And what is the purpose of that? Is it related to the pain, and is the pain related to protection? But why do we still have pain weeks later? And so there's a whole lot of different potential mechanisms that may have been evolved for a very good reason, but they come out of kilter. And so the nerve damage is significant. I can tell you that in some of the burn patients that we treat surgically that have got very, very good scars that we barely can see, we can map out the surface area neurologically, because they're never, certainly out to a year, they haven't retained their sensory capacity, hasn't returned to what is to an equivalent body site elsewhere. So
Mhm.
it's a fascinating area, I think. And as I say, there's lots to know
yeah,
that we
yeah.
don't right now. Yeah.
I won't keep you too much longer, but going back through just all of your experiences, is there something about the skin or something about burns or something about plastic surgery that has just kind of like taken the cake in terms of blowing you away?
Well, I think plastic surgery blew me away right from the beginning when I could see it was the guys at the time when I went first was in the operating theatre as a med student, were doing microsurgery and taking one part of the body and re-establishing it in another part of the body. And it was such a creative, innovative specialty that, and tissue engineering as being a space that with the cell therapies that I've sat for a long time. But it's that creative, innovative sort of or cutting edge uh, space that really just I got hooked right at the beginning. Plastic and reconstructive surgery can be extreme makeover and extreme rebuild. I work in the extreme rebuild end of the spectrum, but there's so many of these different techniques. You've got to keep your eyes open and see what others are doing and harness the knowledge and the engineering, the science that's out there, and bring that to bear so that you can do the very best for the person in front of you. So that's the kind of space that I find the most exciting, is that knowledge and the science and technologies is just like a mushroom cloud. It's growing exponentially, and it's harvesting that and saying, hey, that's part of my jigsaw. You come play with me, because
Mm-hmm.
that will help somebody whose life is changed in an instant with a burn injury. And one day we will be able to regenerate. I got a very special Christmas gift from the senior nurse at the Children's Hospital, Tanya, a few Christmases ago. It's very small, and it's a Bacta tank, a replica from Star Wars. And Luke Skywalker, when he gets his hand chopped off by Darth Vader, and they gave him a mechanical one. It was bad parenting, you'd have to say, but he gets
Yeah.
his mechanical one. That's these days. That technology is coming through now. But when he gets blown away by the stormtroopers, they put him in a Bacta tank, and he regenerates.
Mm-hmm.
We just need a Bacta tank.
Yeah.
One day we just
Yeah.
need a Bacta tank.
Yeah.
Yeah.
Yeah. What about the most challenging aspect is the kind of the hardest period that you've found, or the hardest periods?
The hardest times are, I guess, when people don't survive, and trying to uh, not rationalize but understand, you know, interrogate and be brutally honest if there's anything you could have done better, and make sure that you learn from it to make the subsequent opportunities for people's survival to be better. But sometimes uh, the decision making around is very stressful and challenging when you're making the decision that enough is enough,
Mm-hmm.
and there is nowhere to go. There's no further to go, because we have to be very mindful that at some point we do our very, very best, but at some point the injury is beyond the capability of survival.
Mm.
And that's very hard decision making, and to coach the youngsters through that, because sometimes we are very good at doing and we keep doing, but sometimes it comes a point where you should not do. And
Yeah.
hard. That's hard, because we're hardwired to do.
Yeah.
and, to, and sometimes helping best is by standing back and supporting.
Yeah.
And they're difficult times.
Is there no, sorry, go ahead. Go ahead.
They're-
No, no, I was going to just chorus what you were saying anyway, but when you say, you're talking to younger doctors or registrars going through it, and
yeah.
what kind of advice do you have? Like, at which point do you have to say, okay, I've taken the lesson, and now I need to, be easy on myself, or, do you have a strategy or strategies for being kind to yourself in those situations as well?
I think that's it. Yeah, that I, my personal approach to all this is that if I've done my best, I can do no better. But I need to learn. So I guess as as I've spoken to you, that I'm fascinated and interested in understanding the mechanisms, because then I can do better. And that has been my coping strategy all the way through, always to keep learning, so that I can always try and sort of improve things. And by doing that, then I'm in a space mentally that I can, yeah, okay, it wasn't great, this is the outcome, this is fine, but we did our best, and this is how we're going to rationalize, and this is how we can learn from it, and these are the next set of experiments or whatever it may be. And so always learning something from each day, whether it's small or large, is an important thing in my personal psyche. And I think then, as talking to the juniors, you need to invest in people, and the people you need to invest in are those around you that care most for you as well,
Hmm.
and because they're the ones that will look after you when you need it.
Yeah.
and,
Yeah.
and so I often say you keep something of the best of you for those who care most for you, and I think that's the best kindness you can give to yourself, because then there's people there for you.
Yeah, no, I love it. And just I'll let you go, but with this, the last question, just general advice for someone who's perhaps thinking about going into plastic surgery or even specifically burns, and they're thinking about it, investigating in their head. Is there, yeah, just words of wisdom or?
Well, I think I feel very, very strongly that you should find your own path, and and really find it. I felt very fortunate that I found something that I'm very passionate about, and fascinated by and interested in, because I feel privileged to get up in the morning and enjoy what I do. So finding that question, that spark that goes, "Whoa, I wonder why." Listen to that. Listen to that. And follow it. Follow that road, and then you'll find that you're on a journey that brings out your best self, because you're interested in it, and it becomes part of you. I hope that makes a bit of
It
sense.
it does. Well, it reminded me a lot of something that you made in a talk when, because correct me if I'm wrong, but it's you got 6 children
Yes.
and married to a surgeon as well, and the advice given to, I think it was your class or maybe someone else's class, was you can't have both, but you've disproven that. But do you remember what I'm referring
Yes.
to when you, yeah, would you speak
Well,
a little bit?
yes, I went to speak to the med students, because they'd been told by they had a talk on careers in surgery, and the people speaking to them have said uh, that if they were interested in a career in surgery, then they should the women in the group should very seriously consider that would impact on their ability to have children. So I went along some months later to the same group, and I opened my talk by saying, well, I'm a surgeon, I'm married to a surgeon, I have 6 children. So unless you're all committed to having 6 children, you do know you can't have a career in surgery, don't you? At which they all laughed. And I said, well, when somebody came here and told you that you had to consider that you couldn't have children if you wanted surgery, why did you believe them?
Mm,
You find your own path.
yeah, no, I
Do
love it.
what's right for you. You do what's right for you, and you make it happen.
Yeah,
So that's really important. You don't have to listen to all those things that you hear. It's all white noise.
yeah. Yeah, no, I love it. Well, thank you so much, Fiona. And where's the best place for people to find out more about you?
Oh, the foundation, I guess, the Fiona Wood
Yep,
Foundation.com.au.
yep.
Yeah.
Awesome. Well, thank you so much, Fiona. I really appreciate it.
Thank you very much for the chat.
No worries.
Cheers.